Hello, my name is Ravi Vij. I'm from My Cancer Haven. And today I have with me Dr. Mikkael Sekeres, who is a professor of medicine, chief of the Division of Hematology at University of Miami Healthcare System, Sylvester Comprehensive Cancer Center in Florida. Dr. Sekeres has an illustrious record, having trained at both University of Pennsylvania, at MGH, at Dana-Farber, then most recently moved over to this illustrious unit at Sylvester, where he's producing some of the best research in the area of MDS. He's also an accomplished writer, which we will talk to about in a minute as well. So welcome, Mikkael.
Thank you so much, Ravi. What a delight to be asked to participate in this.
Thank you. So I think before we start out, we're going to talk about some recent advances in a minute, but it would be robbing our audience of perspective if we didn't talk about your contributions overall to oncology, which goes far beyond myelodysplastic syndromes. You have been an author of two books and numerous other pieces. You've written for the New York Times. You've written recently a provocative piece for the Wall Street Journal. So can you just, in a few words, tell us about these two books that you have authored, and hopefully our patients and our audience will go and be able to then read these books, which are, I think, remarkable for the content.
Oh, gee whiz, thanks. So just a little bit of background. I actually come from a family of writers. My dad was a newspaper reporter for the
Okay.
Providence Journal. Yeah, yeah. So, I always think as a parent, our job is to pass down to our children one skill that will keep them from living in our basement for the rest of their lives. And in my family, that skill was writing. So, I almost think I approach medicine and science with a liberal arts brain. And I probably tell stories about science in my own mind that differ from true scientists like you, and how you put all these complex facts together in understanding cancer and how to treat cancer. So my first book, When Blood Breaks Down, is about three people who were diagnosed with different types of leukemia. And I take the reader through their stories and use it as a way to also tell the story of leukemia, from when it was first described to how therapies were developed, and how that interplay occurs as we sit down and talk to patients about the types of therapies that they might receive. And I actually find my patient stories incredibly uplifting, and I'm convinced it's one of the reasons I haven't burned out from medicine, and it's all about my patients. So I try to sing their songs in the book When Blood Breaks Down. Drugs and the FDA is a different book. I spent 5 years as a member of the Oncologic Drugs Advisory Committee at the FDA. And that's the committee, if you're reading in the newspaper that an FDA committee today voted in support of approving this drug for cancer, that was our committee. And I actually chaired that committee for a couple of years. So drugs in the FDA is really a history of the FDA and how that history plays into the decisions it makes today. And the thread, the storyline that runs through the book is actually about the breast cancer drug Avastin and how that was approved by the FDA using their accelerated approval mechanism. And then the FDA was debating whether or not they should actually pull it from the market for that breast cancer indication. So the book is about all the history that leads up to that decision, and then kind of poses the question whether that decision reflects the fact that the FDA works really well, or does it reflect how the FDA doesn't work? So two very different books, but I'll tell you, a lot of fun to write them. And, I look at our job as doctors in part to educate our patients, educate our family, and educate the public.
That's remarkable. As somebody said, you said you came at it from the, from more of a literature arts background, and somebody said that you can, science gives you knowledge and arts gives you wisdom. So I think that you have obviously incorporated both of these, important areas of life, and hope you have many more books that you have in mind that you will be having out, and I'm sure all patients and physicians like us also obviously clearly learn a lot from these books.
Gee, thanks. And I think my wife might debate you on the wisdom aspect of me, but aside from that, I totally agree.
Well, let's just talk a little bit about myelodysplastic syndromes, which is only a small part of what you're contributing to the medical field. But obviously, this is an area where you are one of the leading experts in the world. So, for the audience, just a little bit of how you think about myelodysplastic syndromes. Our program today is focused more along the lower risk myelodysplastic syndrome and a couple of the recent major advances. But just how do you think about it?
So it's a great question. Let's start off with kind of a basic concept. And I always thought this was basic, but it turns out it's actually really complicated. Myelodysplastic syndromes are a type of cancer. And we know that we see patients who have a variety of aggressiveness of cancer. We have some patients where you say, oh, yeah, you have cancer, just like we would say, yeah, you have high blood pressure or diabetes, and we don't get too excited about it, and we treat it, and people live a long life. And then we have other cancers where we get very worried about them, and we jump in and start therapy immediately, because if we don't, someone could really suffer untoward consequences of that cancer or even die. And the same is true with myelodysplastic syndromes. It's a cancer of the bone marrow. And the bone marrow is the factory that makes all the cells that wind up in our bloodstream. The red blood cells that bring oxygen to our tissues when that's low or anemic. The white blood cells, that's our immune system, it fights infections. And the platelets that help stop bleeding. So with myelodysplastic syndromes, that factory is broken. And people will, the majority of the time, come to see me because they have some degree of anemia. And MDS is broken down into lower and higher risk subtypes, just like other cancers. Lower risk myelodysplastic syndromes, people can live with for years. And it may involve a mild anemia or mild low platelet count or low white blood cell count. It may require some therapy, or sometimes it doesn't. And one of my patients once referred to his version of myelodysplastic syndrome as mild dysplasia syndrome. Because for him, he didn't actually need any therapy. And he lived more than a decade without needing any therapy. Higher risk myelodysplastic syndromes, on the other hand, is actually something that's very worrisome. And some people may have heard myelodysplastic syndromes as being described as a pre-leukemia. We don't like that phrase because really fewer than 1/3 of patients with myelodysplastic syndromes actually progress onto acute leukemia. So it really isn't the case with the majority of people. But higher risk myelodysplastic syndromes is at high risk of progressing into acute leukemia. And that's a diagnosis where we treat people right at the very beginning. As soon as we hear that there's a diagnosis of higher risk myelodysplastic syndromes, we start our patients on therapy. With lower risk myelodysplastic syndromes, we often wait until a patient's blood counts or symptoms are so severe that it really forces our hand to start therapy.
So what has been the standard of care till recently in the low risk myelodysplastic syndrome? When a new patient comes to you, how do you think through things?
Well, like I said, the majority of people who have lower risk myelodysplastic syndromes have some degree of anemia. So the number one prescribed drug, at least in the United States, for the treatment of lower risk myelodysplastic syndromes is a hormone. It's erythropoietin. So this is a hormone our body produces to stimulate the bone marrow to make more red blood cells. Well, we can also give this hormone as an injection. And if you were to say to me, well, what's the chance that somebody's blood counts, their hemoglobin is going to improve? What's the chance they're going to become less anemic when given one of these drugs? It's on average around 40%. And there are a couple of studies that have looked into this. On the left, I have actually a combination of studies that were conducted over 20 years in over 1,500 people that shows that on average about 40% of people get better. They have some improvement in their blood counts to erythropoietin. On the right is a randomized trial. It's a little more complicated and nuanced, where on that study, people were randomized to getting that erythropoietin, that hormone, or placebo. And on that study, while they were being followed during the first 24 weeks, only 15% got better to the hormone compared to 0% on the placebo. But with further follow-up, that number rose to 35%. So when people come into my office, I'll say the chance of getting better, of having that anemia improved with the hormone erythropoietin, is somewhere in the range of 15 to 40%, probably closer to 40%.
And obviously, we've had for a select group of patients till recently another drug, lustapercept, and I understand this may become also a drug that you would consider giving to your newly diagnosed patients, which we'll talk about in a few minutes. But what has been lustapercept's role so far?
Yeah, it's a great question. So luspatercept works on some of these abnormal bone marrow cells and encourages them to make more red blood cells so people become less anemic. And it was initially approved in a narrow subset of people who have myelodysplastic syndrome. So to get the drug, people had to either have been exposed to the hormone erythropoietin already and the drug stopped working, or exposed to the hormone erythropoietin and it didn't work, or be in a situation where that hormone is unlikely to work. Combined with this, patients had to have a subset of myelodysplastic syndromes that included something called ring sideroblasts. What the heck are ring sideroblasts? Well, if you look under a microscope at bone marrow cells, when pathologists are trying to identify what they are, they add a dye to them. And some of the cells take up the dye in this beautiful ring, almost like the planet Saturn around it. That's a ring sideroblast. And it's associated with a very specific genetic mutation called the SF3B1 mutation. So patients had to have a ring sideroblast or that SF3B1 mutation and had to require blood transfusions and had to have already been exposed to the hormone erythropoietin to then get onto this study. And on this study, patients were randomized to receive luspatercept or placebo. So then whether or not they got better to those drugs was assessed. And it turns out that the likelihood that someone would improve on the luspatercept was 38%. So out of 10 patients who were enrolled on this trial, 4 appeared to get better on the luspatercept with a rise in their hemoglobin and no longer requiring blood transfusions for a period of time. So that's kind of a big deal, and it's a pretty well-tolerated drug. Now, on the placebo arm, it turns out 13% of patients seem to get better all on their own. And it just shows you how heterogeneous myelodysplastic syndrome is and how some people can go through periods of feast and periods of famine, periods where they need a lot of blood transfusions, and then just for random reasons can go an 8-week period without needing a blood transfusion.
And it seems like the blood transfusions were something that you could do without for a while.
So sure. So what we do, I think about the period of time somebody goes without a blood transfusion, and I also think about the time my patients invest into coming into clinic and getting a shot. And I think about everything in their lives that gets them into that clinic. So from the moment they walk into the car, drive against the traffic in Miami, which can be substantial, park the car, make it into clinic, have their labs drawn, make it into a room to see me, and then make it into an infusion chair to get their injection. It's a lot of time investment. And I always think to myself, is it worth it for that person to invest all that time to get an injection for the amount of time they're going to go without a blood transfusion? So what this shows is that, as I mentioned before, 38% of people getting the luspatercept went 8 weeks or longer without needing a transfusion. Now, let's actually be more rigorous than that. Let's look at how many patients went 16 weeks, so a 4-month period, without needing a blood transfusion when they got luspatercept, and that number is about 20% of patients. So as you go further out, fewer and fewer patients benefit for what I would think is a meaningful period of time, like at least 4 months without needing a transfusion. But in lower risk MDS, 20% is about what we get. So that's just what this figure shows. Now, this is a little more complicated. What it shows, if you look at the red dots, a red dot is every time a person needed a blood transfusion. A long blue line is how long they could go without needing a blood transfusion. And you can see if you look on the left at the top, gee, there are some folks who went 2, 3 years without needing a blood transfusion. Actually, a patient who went the longest period of time without needing a blood transfusion on this trial was a patient I treated myself, and she's still going strong without needing a blood transfusion. What this also shows is that there are people who can go a period of time, maybe 10 weeks without needing a transfusion, and then they get their first blood transfusion. Some people will give up then. They'll say, all right, well, this person has started to need blood transfusions again, the luspatercept isn't working. That's actually the wrong way of thinking, because then they can go a significant amount of time afterwards, a year or two, without needing another blood transfusion. So the purpose of this slide, this figure, is to show that there are people who will go a short period of time, need a blood transfusion, but don't give up then. Keep going with the luspatercept to see if there can be some even better benefit after that point.
So obviously that brings us to some of the recent data. To put in context, obviously we had to go through where we came from. So what can you tell us about this COMMAND study that was presented recently at a major academic meeting?
Yeah, so the previous study, the study that got luspatercept approved by the FDA, was in patients, as I mentioned before, who had ring sideroblasts, SF3B1 mutation, and who already had been exposed to that hormone erythropoietin. This study moves the luspatercept more to the front line. So people who are diagnosed with myelodysplastic syndrome already need blood transfusions, but haven't started anything yet, not even the hormone erythropoietin. And it randomized patients to getting luspatercept or the hormone erythropoietin to see which was more likely to result in a person no longer being anemic and no longer needing those blood transfusions.
So what did the trial show?
So on this study, the percentage of people who received luspatercept and no longer needed blood transfusions was 58%. Compare that to 31% for people who got that hormone erythropoietin. And remember what I showed you earlier, the range of people who get better to erythropoietin is somewhere between 15 and 40%. So that 31% falls right into that range. So people who received luspatercept were almost twice as likely to not need a transfusion when they got luspatercept compared to those who were treated with the hormone erythropoietin.
And I understand that it seemed that the benefit was across the subtypes of patients, some more than others, perhaps?
Yeah, I think that's a great way of saying it, Ravi, some more than others. So remember what I said before about the first study that got luspatercept approved. You had to have ring sideroblasts or the SF3B1 mutation. This study, you didn't have to have ring sideroblasts or SF3B1 mutation to get onto the trial. But when you look at those who had ring sideroblasts, those who actually had the ring sideroblasts, gee whiz, did they do much better with luspatercept. 65% of them no longer needed a blood transfusion compared to 25% who got the erythropoietin. But if they didn't have those ring sideroblasts, then the differences disappear. Then erythropoietin is just as good as luspatercept. So my take home from this, even though the drug wound up getting a broad label from the FDA based on this study, so you basically need to have myelodysplastic syndrome, need to have blood transfusions or a low hemoglobin, and then you can get luspatercept up front. I don't think it works equally well in all those people. I really reserve it for my patients who have ring sideroblasts or the SF3B1 mutation. I think patients who don't have ring sideroblasts or that SF3B1 mutation, it's just as good to give them the hormone erythropoietin at first, and then maybe consider luspatercept in the second line setting after the erythropoietin no longer works.
And then the other study is about a drug that is yet to get onto the market, but hopefully will be added to the armamentarium of drugs that we have in low-risk myelodysplastic syndrome. So what can you tell us about imetelstat?
Yeah, so imetelstat is what's referred to as a telomerase inhibitor, which has to do with the coiling and uncoiling of DNA in the cell. And this drug was also looked at in people who had lower risk myelodysplastic syndromes, a very similar patient population to the very first trial that got luspatercept approved by the FDA. Patients had to require transfusions. They had to have lower risk MDS, but they didn't have to have those ring sideroblasts or that SF3B1 mutation. They were randomized to get the imetelstat or placebo and then followed over time to see if they no longer required those blood transfusions.
And what did the study show?
Well, interestingly, the study showed that the likelihood of achieving transfusion independence, meaning no longer needing those blood transfusions, was about 38 to 40%, very similar to the luspatercept. Interestingly, also, the placebo arm in this trial, 15% of them just randomly no longer needed blood transfusions for an 8-week period. So emphasizes the importance of conducting randomized trials in lower risk MDS so you can figure out what the true absolute difference is between those patients who just randomly are not going to need blood transfusions and those patients who are truly benefiting from an intervention like a imetelstat. When you go out to 16 weeks, remember, I think that's more meaningful to my patients. 31% of patients benefited from the imetelstat compared to 6 or 7% of placebo, which is just background noise. So I do think this drug works in about 1/3 of patients who have lower risk MDS.
So, is the benefit sustained?
Yeah, another great question. So again, I always think about my patient who has to wake up, get out of her house, get into the car, drive to the cancer center, and go through all this rigmarole to get a treatment for MDS. And in this case, the average duration of response, in other words, the average duration people went without needing a blood transfusion was about a year. And in my mind, going a year without needing a blood transfusion is probably worth the effort of going to a cancer center and getting an injection of a drug for your MDS.
And the benefits were, as you said, sustained, and it appears that it did work pretty well.
Yeah, so, typically when I see somebody who has anemia with myelodysplastic syndromes, I wait until their hemoglobin drops down to 8 or less before I give them a blood transfusion, because that's when I think my patients start to get symptomatic. What this is showing is that the hemoglobin rose to an average of 11. And if you have MDS and you've been monitoring your own blood counts, you'll know that a hemoglobin of level is like 11 is like a dream come true. You really feel good then. So not only were patients having a benefit in terms of not needing blood transfusions in, like I said, about 1/3 of them, but the rise in hemoglobin was also pretty substantial.
And it seems like this is not just like any growth factor. We've been talking about erythropoietins and rostapercept, but this may actually be attacking the biology of the disease.
Yeah, so like you said, and you've really gotten to the meat of it, Ravi. With hormone therapies, we're not modifying myelodysplastic syndromes. We're trying to squeeze every last ounce of production of performance out of the remaining normal bone marrow cells. But with a drug like imetelstat, it does seem to be modifying the dysplastic cells themselves, the cancerous cells. And this is demonstrated by the fact that among the patients who were enrolled on the study who happened to have the SF3B1 mutation, they didn't have to have it to get on the trial, but some patients did have it. There was a decrease in the amount of that mutation that was measured over time. In other words, the imetelstat was actually modifying the myelodysplastic cells themselves.
Now, this drug, unlike hormones, has a little more in the way of side effects. Is that correct?
It is. So that's the downside to it. When you look at a drug like erythropoietin, which is a hormone, or luspatercept, which we can debate whether it truly modifies the myelodysplastic cell itself, those drugs don't have a lot of side effects associated with them. So if you see a more modest efficacy, you kind of think to yourself, yeah, but there are also modest side effects, so maybe it's worth it. This drug has more substantial side effects. So patients did have a drop in their white blood cell count and in their platelet count while they were getting this drug. Most of the non-hematologic side effects, so side effects that may have affected other organs, were pretty mild, so it seemed to be pretty well tolerated. But I think the combination of the fact that it has side effects and its efficacy has led the FDA to say, you know what, we're not going to rush this approval. We're going to focus on this drug in the middle of 2024 before we make a decision. So we're still waiting for the FDA to address this drug to see whether or not it eventually is going to get approved.
And one of the things before we wrap up, wanted to touch upon was you had a piece in the Wall Street Journal recently that has, a lot of people been commenting on and very provocative, saying, "Do all patients with MDS require a second opinion?" So, could you tell our audience about this finding of yours that suggests that this is what should be done?
Sure, this was a really interesting group of happenstances that occurred all at the same time that led to my writing a piece for the Wall Street Journal. I was in clinic and a man was referred to me because he had a diagnosis of acute leukemia. Well, I met him and looked at his blood counts, and I had the outside pathologist report. He was diagnosed at a local hospital here in South Florida. And the pathologist report said, yep, he's got acute leukemia in his bone marrow. But when I looked at his blood counts, they were abnormal, but not as abnormal as I normally see with my patients. So something didn't feel right about his whole diagnosis, and he actually felt, not too bad. So it wasn't all adding up in my mind. So we repeated the bone marrow biopsy in him. Around the same time, we had just published a paper of a study that we're conducting through the National Institutes of Health. And it's a study where we've opened up this study at over 150 centers around the country to enroll patients who have a brand new diagnosis of myelodysplastic syndrome, or they think that they do. We actually enroll them before their very first bone marrow biopsy. And in that study, as information was coming in, we noticed that pathologists who were making the diagnosis of myelodysplastic syndrome at their local hospital, like we were getting information from states all over the country, were making a diagnosis that differed from the diagnosis that was made by our expert pathologists who were analyzing the same bone marrow samples centrally. And it turns out, we actually quantified this, it turns out that 20% of the time, there was a discrepancy where a local pathologist may have said, yep, this person has MDS, they've got a cancer, and our expert pathologist would look at the same bone marrow sample and say, no, they don't, they've got a vitamin deficiency. Or the opposite would happen. Someone would be told locally, you don't have cancer, and one of our pathologists would say, yes, they do. So 1 out of 5 patients was given the wrong diagnosis. We then took a deeper dive in this, and it turns out that 10% of those patients actually received the wrong treatment. So we published these results. Same time this man came to see me, his bone marrow biopsy that we repeated came back stone cold normal. And it turns out that he actually had a vitamin B12 deficiency, which sometimes can mimic acute leukemia. Well, when we gave him vitamin B12 shots, his blood counts went back to normal. So I think it emphasizes the fact that with rare cancers like myelodysplastic syndromes, right, which only affects about 4 people out of 100,000 in the United States each year, it is really critical to go for a second opinion, not only on the best treatment, but to make sure that that diagnosis really is what it is.
No, I totally agree. And that brings back a memory of when I used to look after MDS several years ago. I was sent a patient for a stem cell transplant with a bona fide diagnosis of MDS. And the patient had Crohn's disease and hadn't been actually absorbing copper. So it was actually a patient with copper deficiency who was sent to me for a transplant and was very happy when we told him all you need is some copper supplementation.
I bet he was. It's
No,
amazing, isn't it? We see it all the time.
it is.
We
It
see
is.
it all the time.
Thank you for doing this piece because it's a very important thing for people to know. Well, I can't thank you enough for spending time out of your busy day to educate us about myelodysplastic syndrome and some of the recent advances in the field. And hopefully, you will be coming out with a new book soon and a new piece, either in the New York Times or Wall Street Journal. And as you said, you're on both fronts, art and science, and you contribute equally to both.
Thank you so much for the opportunity. This was great.
Thank you very much.